All right, you guys ready? Um,
So
so
it's 2 o'clock.
yeah.
So forgot about that.
So this might be a little bit quicker lecture than I probably anticipated, but so this is about just using sedation in the ICU. Obviously, that's a very, very common thing across the board. So most of this is based on just current guidelines that are based from SCCM. They were there in 2013, and then they updated them a bit in 2018. And there's been a little bit of updates here or there, but nothing major that's changed. So unfortunately, not a lot to change because there's really not that many new drugs to use, and just more strategies change. So we're trying to cover sedation, pain, delirium, but the guidelines that come from SCCM are called PADIS, so pain, agitation, delirium, immobility, and sleep. But the last two are important, and we'll kind of go over those. But I think most of the time what we deal with is sedation, pain, and delirium in the ICU setting. So just statistics-wise, on average, you're looking at greater than 5 million people being admitted to the ICU. Average stays end up being 3.4 days, and there is a huge plus or minus to that, and that's a lot of factors. People get sicker, they get new infections, new events occur, and unfortunately, delirium and issues occur, which sometimes can increase the length of stay. And it's a high mortality environment that we all know. It's a 30% mortality sometimes. I feel like we do a little bit better than that here, but it's still the average, and it's expensive. So each day that we can reduce is a significant reduction in just overall healthcare cost and time for the patient. So 4,500 is the average, but sometimes you'll see averages going up by $7,000 to $8,000 up to $10,000 per day in the ICU setting. And then about almost half the people at some point require some sort of support, and a lot of times mechanical ventilator support. Reasons for sedation are pretty, obvious at the end of the day. Procedures, when we do any of the procedures that and some of you guys have been involved with, we always use some level of sedation. We try to avoid a significant amount if we can help it. Obviously surgery, and then obviously mechanical ventilation. And within those, there's the threshold for mechanical ventilation is pretty low. I mean, that's a whole separate lecture in itself, but a lot of just hypoxemia, hypercarbia, respiratory distress, acute heart failure, any NMDs, or severe acid-base disorders all require mechanical ventilation. So those are just a lot of reasons why people end up on the vent, and a lot of why we're 40% of the time someone may require mechanical ventilation and hence sedation need for it. RAS scale. Again, those of you that have been with me, that's like the first question I ask is what is our RAS goal and how are we going to adjust it for the day depending on what's going on. It is a scale that we use to assess consciousness in a sedated patient. GCS scale is hard to use when they're sedated, they're confused, they're not able to follow all commands. So you can kind of get an idea, but the RAS scale is kind of how we determine how sedated we are and if we're meeting our goal at the time. So calm versus agitated, verbal stimuli, how they interact. If you do interact with them versus if they hold eye contact, if they're not able to hold eye contact, they're moving around kind of spontaneously, not purposeful. And any sort of response to like physical stimuli will determine how deeply someone's sedated versus how lightly they are sedated. This is what a lot of the nurses use when we tell them the RAS goal is basically the scale and what they convert those numbers to. We try to aim for 0 to -1 a lot because we want them to be as awake and interactive as possible. The more interactive they are, the better at the end of the day. But it also comes down to how stable they are hemodynamically, neurologically, and respiratory wise for us to determine how weak or sedated we need them to be. And then the times we go as low as -4 to -5 for a completely comatose status. So, but the lower the sedation need, the better the RAS, the scale, the more likely you're able to get them extubated sooner when they're ready to be extubated and avoid delirium issues. Uh, just like anything else, using sedation does have its own consequences. And then determining whether or not someone needs it is a factor. One of the key things I think is, especially when mechanically ventilated patients are in the ICU, is a lot of people want them to be more sedated. Makes things a lot easier. When they're not sedated, things are a bit more difficult because they are more interactive. Sometimes it might be a little combative. Sometimes they might be moving around more and require more reorientation. So that part has to be judged on whether is it affecting the safety of the patient and barring us from seeing any improvement, or is it requiring a little bit more effort to keep them oriented enough or just reoriented enough so that they're not fighting the ventilator as much. Sometimes it might be that every 10-15 minutes they might require, hey, you're in the hospital, you have a tube down your throat, just relax, and they might give you 30 minutes before they do it again. But that might at times be better than keep them so sedated that it becomes a cycle. They become sedated, they become more groggy, they become more confused, and then you try to wake them up, they become more agitated, and it just becomes a cycle of keeping them more and more sedated and extending our time on the vent. So it requires frequent assessment. RASCL obviously is important, and that's how the nurses will titrate based on the goals that we set and using the medications that we provide are okay with. And also frequent assessment. Being in the ICU setting, you're supposed to be monitored very closely, so they get seen over and over again. One of the reasons why the limited number of patients are limited number of beds are available in the ICU is so that we can keep appropriate monitoring, because they do change 1 hour to the next, sometimes very drastically and significantly. So there's been a ton of studies. Obviously, critical care is one of those fields where doing full studies is a little bit difficult, where you can randomize patients completely, just based on ethics and just feasibility sometimes. So there's a ton of, one of the few things that is sedated pretty well and heavily is sedation, alongside like ARDS, and then so of some of the more recent ones, they obviously tested light versus deep sedation. There were 6 studies that they tested or reviewed, 3 of which were controlled trials. And across all of them, they noticed that extubation time was decreased with light sedation. One showed decreased need for tracheostomies, and 4 showed no significant difference in extubation rates. Those would obviously make sense. I mean, when they get into that cycle, we end up using up more time on the vent. Eventually, it ends up becoming we have to, and we do this now, where we have to do the trick because we can't assess them properly to see if they're ready to be extubated. A lot of times they're so combative or so confused that they're fighting you while you're trying to wake them up, and it's hard to tell, are they in distress because they are confused and agitated to do that, or are they actually in respiratory distress, when it becomes a little bit hard to determine, and then the risk benefit doesn't really fit there. Average extubation rates are about 15%, or 15% is a reintubation rate whenever you do meet criteria. One of the criteria to meet is neurological status. If someone isn't neurologically capable of protecting their airway, it's almost an automatic not to extubate safely. So when you get stuck in that cycle, it makes it hard to say yes or no. There are times where we kind of say, okay, everything is fine, the mechanics are fine, the vent numbers are fine, the pressures are fine, and this is all this agitation, and we do take the tube out, but then you kind of are taking a little bit of an increased risk, but you have to be very judicious to say that that's what it is and not because it's respiratory mechanics related. So these studies would kind of fit that picture and make sense. So their final recommendations along those reviews were to use light sedation over deep sedation in critically ill patients. They've done some smaller studies that shown positive results with no sedation. They've noted that there's been no increase in psychological issues post-extubation. I know there's always a worry that there's PTSD and depression They've also looked at those studies to see how often do people end up with PTSD or depression post an ICU stay, but for this part at least, they have noted no issues post extubation and discharge out of the ICU setting, and really no increase in workload, but they noticed a decrease in ventilator days. The Even in my old place or during fellowship, I mean, that was pretty common for us. Was we would have them awake all the time. They would literally be playing video games on their phone while on the ventilator. As long as they were comfortable, synchronized, and stable, they could be off sedation, making phone calls, video chatting with their family. I mean, obviously not chatting, but videoing with their family, and it would be okay. We would get them up and out of the bed into a chair with the tube still or in the mouth rather than like a trach. So we would push to that point, which we'll go to another point later with regards to mobility, but that's how awake they can be if they're stable. And I believe here in the cardiac ICU, they are doing that more too, is getting them out and then more mobility even while they're on the vent. So it's doable, and it does improve outcomes to some degree. You're less atrophy, less deconditioning, and then likely to decrease the ventilator days because one key factor is taking care of the mental status. But there's nothing hard in the research to say that that's what we need to do yet. There's plenty of evidence to support it. So, but it is resource intensive a little bit. I know they say no increase in workload, but if you think about keeping them awake may not require as much because they just have to monitor the patient and continue to reassess them to make sure they're stable. But doing things like getting them out of bed and stuff obviously requires more intensive approach because you need a couple of therapists, you need the respiratory therapist, you need the nurse in the room, and you need one of the intensivists nearby just in case. So that part is a little bit more resource intensive. The drugs, I think a lot of us are familiar with, propofol being the first one. Most likely, mechanism of action is that it affects the GABA receptors and reduces glutamatergic activity via the NMDA receptors. Its onset is pretty quick, on and off. Between 9 minutes, I would say I think average is probably 20 to 30 seconds, and they're usually pretty out if you have the correct dosing in there. But about 9 to 50 seconds is for onset. Duration is only 3 to 10 minutes, although also depends on how long someone's been on it for. And there's plenty of times where people take longer to come off of it. And especially if they've been on combination sedation, then it may take much longer for them to come off sedation and than you'd expect. Half-life is about 40 minutes. Can accumulate in tissues, so that's one of the reasons why it can take to increase in time to release for someone to wake up. And then titration has to be pretty well monitored. And also a number of side effects for arrhythmias, tachyarrhythmias, prolonged QT, hypertriglyceridemia. So we normally check the triglyceride levels after the first few days and keep an eye on them because high enough, you either have to stop, and if it doesn't come down, you might be worried about pancreatitis as well. And then can see mild decrease in clearance in patients undergoing temperature targeted management post cardiac arrest. Propofol infusion syndrome, very rare. I feel like I may have only seen it a couple of times, but it does happen. Usually when you're on really high doses for multiple days, you're likely to see it does have a high mortality rate. Can see dysrhythmias, heart failure, hypotension, acidosis, rhabdo. One of the key things is the green urine. That would be something that might be even on a board exam, at least for ICU. And then really there's not much to do other than supportive care and to avoid using it again. Benzodiazepines, another pretty commonly used medication, binds to this area specific benzodiazepine receptors that are synaptic GABA neurons within the CNS. Also pretty quick acting for the most part, 25 minutes. Duration is much longer, and half-life is longer as well, 6 hours of duration versus 2 to 6 hours of half-life, and can accumulate. And that's another very, very common one that we see. That's why we try to avoid benzos as much as we can and just use them as PRN rather than drips. But there are those patients that come in who have intolerance because they're IV drug users or alcoholics, and they just require significantly more uh, of any of the benzos to actually sedate them properly when they need to be. And then unfortunately, you expect them to wake up within hours, but sometimes it's a half a day goes by, a day goes by. It may even take 2 days before you actually see them wake up in actual practice. But during those first hours when they're not waking up or showing any signs of showing improved neurological status, you kind of end up having to make sure that rule out strokes and things like that as well. Also, I mean, it goes down to risk and benefit again. It's one you can wait it out and see if they wake up, and you can be 99% sure that it's just the benzos. But sometimes when it's taken that long, you also want to rule out anything that's reversible or potentially reversible. So you end up having to evaluate that and get a scan if you need to. That's probably more in practice than like a written guideline. And then it's primarily cleared by the urine, and then clearance is reduced in hepatic and renal failure, and that's another common two things that take effect. Someone comes in post cardiac arrest or hypertensive, they have shock liver, they have renal failure, and then eventually they end up on these medications, and then it takes them a while to wake up. So a lot of the other variables that come to play. Dexmedetomidine, looks like a couple of my things got messed up. I don't know what those questions are. Question marks are there for. There's probably supposed to be commas. So dexmedetomidine is a selective alpha-2 adrenoreceptor agonist. Activation of G proteins in the brainstem, inhibition of norepinephrine released, and sedation. It's primarily anxiolytic medication that we can extubate on, which is kind of the benefit of using this over everything else. It has relatively short onset. It's titratable. It doesn't affect blood pressure and respiratory status as much. It can cause hypotension and it can cause oversedation, but generally speaking, it doesn't do. Bradycardia is probably the most common thing you would see first, and then sedation, but they're probably equal at the end of the day. But they're very easily reversible. You just basically stop it, and after a little bit, it will improve. But compared to the other drugs, has the least amount of other issues of oversedation or respiratory depression or immediate hypotension. Ketamine, I think that is one that I know the ER uses frequently. We don't use it as much, but I think that practice is changing a little bit, using it more and more now. It's a great drug that helps not oversedate a patient, and we can also extubate on if we needed to. But it basically creates the cataleptic state, more of a dissociative state by direct effect on the cortex and limbic system. It's non-competitive NMDA receptor antagonist that blocks glutamate and has both central sympathetic stimulation and inhibits catecholamine uptake. Negative inotrope effect as well. Duration is probably within the line of everything else so far, relatively short, 5 to 10 minutes. Duration is only 1 to 2 hours. Half-life is only in that 10 to 15 minutes. But delirium, agitation, hallucinations, irrational behavior, those can become a problem sometimes, especially when they're first starting to wake up out of their sedated state. And just like the others, unfortunately, it does have cardiac issues as well, with tachyarrhythmias, hypotension, cardiac decompensation for some patients, and then withdrawal. So post cardiac surgery, propofol is probably the best as the shortest onset. So if they're ready to come off the vent, they're pretty aggressive about getting people off the ventilator. And the CVICU side, most of those patients are extubated within an order of hours after being out of the OR. If everything is going according to plan. And there's plenty of evidence to support that, and including what sedation to use. And that's propofol. 7 RCCs just found 1.4-hour decrease in extubation time. Their time on the vent is already low as it is, so hours make a difference in terms of reducing their time on the vent and the complications. So I'm fine. So for non-cardiac, patients, propofol versus benzos. Most of the studies came out with propofol as the winner across the board, with an overall decrease in time to extubation by 11.6 hours and 7.5-hour reduction in time to light sedation. Dexmedetomidine versus propofol, pretty much equivalent. Dexmedetomidine versus benzos, pretty much equivalent for those patients. And then no significant differences were noted in terms of length of stay and ventilator time with use for dexmedetomidine and benzos. So propofol or dexmedetomidine were recommended over benzodiazepines, and a lot of that had to do with increasing neurological issues. So the delirium, agitation, confusion that is more likely to happen with benzos than it is with the others. And I guess in practice, I would say that dexmedetomidine I feel like there's a lot less issues in overall. I feel like more often than not, we get people off the ventilator quicker once we switch over to dexmedetomidine if they can handle it than we would if we just kept pushing benzodiazepines. But based on the data, there was no difference. BIS monitoring, we have I don't know if anyone was with me with recent like the ARDS patients where we use there. So we use BIS monitoring a lot, and some people believe it works well, some people don't, but some of the studies do say that there is benefit for deep sedation because you can't assess those patients easily. For the patient that we're talking about, I mean, the man was paralyzed on nitric oxide, on CRT, on 20 OP, 100% FiO2, on 3 pressors. Like, there's no way other than to, like, this was the only way we can kind of see what sedation levels they were at, but even you could never tell. But that's in practice again versus in reality of the data that support its use in those sedated patients that require paralytics specifically, because it does help you determine whether or not someone's sedated enough for it. You never want to sedate or you never want to paralyze someone who's not properly sedated and on analgesia. That is basically torture. So BIS monitoring comes into play to make sure they're always properly sedated. Any questions so far on the sedation part of it? We do use it when it's hard to get them off the vent, but most times by the time they come out of the OR, they're already getting weaned off the propofol. So use the propofol during their OR or post anesthesia anyways, and then they wean them off and they're usually getting ready to extubate them as it is. So, but if they are doing the same thing that any other patients do with regards to being severely agitated, or that's where it works the best. Yeah, the agitated patient is not fully cooperative, but their mechanics are fine. You just want them to stay calm enough to get them off the ventilator. But you have to take the cardiac side into consideration too, because it has some cardiac side effects. So, but also most of them have a pacemaker before when they come in too. So they do use it. I think for primary sedation, it was propofol ended up being better. It was quicker onset, quicker offset, and get them off the vent quicker. So for them, it's order of hours before they're getting them off the vent. So pain is another significant part of being there. There's plenty of things that we do to the patients, unfortunately, that are painful. All of the procedures we end up doing, from chest tubes to all the lines, the art lines, to even putting an IV line are pretty painful. Art lines, I know the catheter is small, but when you put it in the wrist, in the very like concentrated area of nerves and bundles and muscle and every tendons, all of those things are super sensitive. And as soon as that needle goes beyond that into the tissue, it's very painful. So pain is something that we need to keep an eye on for all of them. Pain assessment using a proper tool, which I believe we use CPOT here, is in assessing that and treating that has shown to decrease length of stay, decrease vent time, decrease sedation needs, decrease mortality rates, even decrease opioid use. But And then one of the key things that a lot of the newer evidence, even from 2013, the updated ones from 2018, and anything else, is always points to analgesia before sedation. So that's where assessing the pain frequently, using a validated tool and treating that before. That doesn't mean using the pain to sedate the patient. It means finding out what the pain is and then treating the pain to avoid over sedating them with sedatives has shown better outcomes. But yes, unfortunately, when we use like fentanyl and those type of medicines too, it does both, sedates them sometimes as well as treats the pain. So you have to kind of be judicious on how we use those medications as well, and that's where adjuncts come into play. Um, so the two known validated tools for pain assessment end up being CPOT and BPS. So CPOT is critical care pain observation tool, and then the other one is behavioral pain scale. These, you can see the tables on the bottom, and then determining which one to use. Both of them are valid, both of them can be used, and both of them can help you decide whether or not someone's having pain for someone who can't communicate with you as easily. But the nurses will usually use CPOT. It's in their documentation. They'll tell it to you if you need to. But when we order pain medication for severity, that's one of the ways they're determining it. But it kind of goes back to our sedation part of it too. If you can reduce the sedation, the patient can be communicative. They can tell you if they're in pain or not. I know there's this belief that someone has a tube, in their airway, and that means they're automatically in pain, which means they automatically need sedation all the time, even though they're saying no. If they're awake, they can tell you, and they will nod their head yes or no if they have pain, and you can avoid over sedating or over medicating them that way. Um, so yeah, so basically kind of what we talked about. Vitals by themselves are not good enough. I know we like to look at it, blood pressure's high, heart rate's high, they must be uncomfortable and pain. Is part of it, but just using that without any sort of other validation is not really recommended. Um, opioids are the common medication for us to use. But the goal is always to reduce the amount that we need to use all across the board. Acetaminophen works great as an adjunct. Post-surgical patients, using ketamine can help reduce the opioid need. Gabapentin is a great adjunct as well. We rarely use IV lidocaine. I know it's mentioned in some places for as a tool for it, but I can't tell you if I've ever given someone lidocaine for the pain. I Yeah, I can't honestly remember ever doing that. I never had to do that. And then NSAIDs, selective NSAIDs are usually not recommended. And then these studies are this is more extrapolated from just post-surgical patients. Obviously, they're the ones who are coming in with obvious reason for pain. This is just another algorithm way to go down and decide what you can consider using. Nifopam is something I don't know if we have here. I actually messaged our pharmacist to see. I know we've gotten some new pain medications. I don't know if this is part of it or not. But this is a more centrally acting medication that helps block pain receptors at the brain level rather than in peripheral. So helping reduce the opioid need. They did research this, hypnosis and cyber therapy. I guess I was skeptical reading about it alone that they actually tested it, but it didn't show any improvements, so they were not recommended. But massage and music therapy actually have shown some benefit, and for those that are able to, it is potentially recommended. We don't have either. I know we have a music therapist, but they come in like when they're extubated sometimes. I don't even know how they get them up there to show up some days. But those have been shown to be helpful. And I know there's the cases where people have put themselves in the hypnotic state and gone through surgery and stuff like that. But I don't know if that's actually validated by any means. But we still looked at it. Um, Delirium. So up to 50% of patients in the ICU develop some level of delirium. Usually when they've been in there for multiple days, they an ICU setting for or a ventilator for 5 days and a hospital for up to 10 days. And like we talked about before, it just has increased costs in general because it does take them longer to be able to be discharged safely. Um, and then 1 in 3 have some level of cognitive impairment in the long term for those that have severe cases. Risk factors, benzodiazepines, blood transfusions, opioids, steroids, otherwise age, dementia, trauma, need for emergent surgical pre-ICU, surgery pre-ICU, and increased Apache scores are all possible. Most of those are pretty obvious. When it comes to blood transfusions, a lot of it just has to do with micro ischemic events that can occur due to the scarcity of the blood. So that causes short-term like hypoxic episodes that can cause a little bit of confusion, but eventually that resolves itself, but the lasting effects can be there. The rest are pretty straightforward. And then for this, we use the confusion assessment method in the ICU, so CAM-ICU or pre-deliric. Those are both validated scales for determining delirium. Here we use CAM mostly, CAM-ICU, and then that's another score that's usually in the chart from the nursing evaluations. A positive screen does have risk of cognitive impairment 3 to 12 months after discharge from the ICU, and then in the short term, increased length of stay. Delirium does not seem to have a link with PTSD post-discharge. Does not have a show increased length of stay to discharge other than home. So going to a facility, it doesn't change much. Probably going to a home, it may increase that chance of not increase the chance that doesn't happen. And then it does not show any association with increased rate of depression, functionality of dependence, or mortality. This is basically the steps that they use to calculate the CAM ICU. So essentially, and for their end, they already have it written out where they will just put the numbers in based on their assessment at the time, and then the right side is the worksheet that they use to come up with the score. And then this is the other model, which is another validated study to determine predict delirium. But most of these are to fill in. So we use these medications when we have to, but in terms of the recommendations, they're not fully supported. So haloperidol versus no treatment, there's no significant differences noted. Recommendation was to avoid them, which we use antipsychotics when we really need them, and that's usually when they're being severely combative and at the point of risk of hurting themselves and others, and are not decisional whatsoever. And then so that's when they come into play in practice. But in general, for delirium, it's not necessarily indicated. Dexmedetomidine versus placebo. There was significant decrease in ventilator days, mostly for agitation, delirium, and then weaning from the vent. Unlike like fentanyl or midazolam or propofol, with dexmedetomidine, you can wean them off the vent with the medication still running. So it's definitely helps us get improve our chances for getting them off the ventilator quicker. Multiple randomized control trials evaluated for bright light therapy. There's no significant benefits, so not really recommended for use. And this is kind of what we all do and monitor is just optimize their sleep-wake cycle, improving their mobilization, hearing, vision, reorientation are all the things that actually do show benefit in reducing the delirium. And then sleep for them is the biggest thing. When they're on these sedative medications, they're never getting true sleep, true REM sleep. So their circadian rhythms are very off, and that affects their confusion, orientation status, and increases the chance of delirium. So getting a better sleep wake cycle, mobilizing them early, reorienting them constantly are all the things that help actually improve their outcome. There's no solid studies for the breast approach. most of it kind of comes down to is just avoid the chemicals as much as possible. Very judicious when you're using any medicine, any of the sedative medications, avoiding the benzodiazepines. And they actually, more recent studies even recommend melatonin over not doing it at all, to help them keep a better sleep-wake cycle. So there are some evidence to show that it has benefit. I personally like using it all the time because I feel like it works. People seem to want something strong to go to sleep. You go melatonin, and then I'm told that they're sleeping, so it works. This is kind of more or less just like a summary slide.
Yeah.
But yeah, that's so. I guess it just comes down to is using the least amount of sedation possible, only using it when we really need to use it, being quick about getting it off when they are on sedation, and when they are off and having delirium issues, avoiding chemicals as much as possible. Mobilization, sleep-wake cycles are very, very important in reducing the chance of delirium. And then controlling the pain is going to have better benefit than just sedating them. Sedating them is going to just lead to a cycle of sedation, more delirium and agitation, more sedation, more delirium agitation, which then is just going to increase their length of stay overall. And then on the vent, because that's when we're mostly have them on deep sedation for. And like I said, those guidelines necessarily haven't changed a whole lot since 2013. Even the 2018 was, like I said, the last review of it all. And yeah, I just think more and more they focus on those last components. And then mobilization wise, like I said, we used to do it. ECMO patients, they'll get them walking around, even with all the tubes in place. Again, just a little bit of very hyper vigilant of everything. We haven't done as much here, but we used to get the intubated patient who's not necessarily ready to come off the vent, but unstable enough, and get them out, sit in a chair for a little while, or get the therapist and get them do just a short walk up and down. They used to help a lot. My residency, we had I think it was like our fifth floor had a terrace for patients that had garden and water fountain and all this other stuff. And if they were extubated and stable, but they were somewhat delirious, they used to take them out there for like even 20 minutes just to sit outside in the sun. And all of those things had pretty good improvements. That one was more just anecdotal for my own visualization, but the other stuff is more based on actual data. So, like I said, this was a little shorter than I thought it was going to be. So, what questions do you guys have?
About the patient around the tube and mechanical ventilation, how do you overcome the stimulation from upper airways and avoid this drooling with the patient discomfort from the tube?
Like drooling, just
Like
that.
if the patient orally intubated,
Yeah.
he has some like a mechanical stimuli in the upper airways, which bring him discomfort, and like if they do the ventilation for a while.
If they're awake enough to be walking around, they'll probably just tell you when they're uncomfortable. They might feel it. It might not be nice looking, but there's really not much. I mean, if they're actually just uncomfortable, discomfort, what I'm thinking about is mostly pain related. But some drooling and that feeling is, I mean, that's, you can just wipe that off and call it a day. But if they're awake enough to be ready to walk around, they should be awake enough to communicate with you.
Yeah, I was seeing one patient who was awake and on mechanical ventilation, and he was able to tolerate. So actually, he was writing and communicating with the writing with us, but he was able to tolerate this kind of ventilation just like during like 8 hours, and then he started to be desynchronized.
Yeah.
So he was coughing, drooling, and so definitely we increased sedation.
Yeah, that'll happen. I mean, you just for those ones, you can give them the little Yankar and they'll do it themselves the whole time and in between. And then if they do become uncomfortable, that's where you have to have a strategy. If you get them off the ventilator, that's the first thing you should be trying to do anyways. But that's the occasion where you can get them off the ventilator. Yeah, but everything else is looking, in the right direction. But you have to just come up with a strategy. Okay, we might be off the ventilator for so many hours, and then you can add something light, but that's where dexmedetomidine might come in. it's a great medicine for that situation. It keeps them comfortable and calm on the vent without making them go to sleep or over sedated or affecting your chance of maybe getting a better outcome the next time you try. But I mean, we get pretty aggressive when it comes to someone's really close to being able to come off the ventilator, just doing 2, 3, 4 times a day to get them to come off the ventilator. I mean, there's no time limit. If it's 2 in the morning and one of my partners is ready to get them off the ventilator, they'll do it then. So the goal is always to get them off as soon as possible and keep the least amount. But yeah, if you need to, there's a little bit of that trial and error to it. Like you're never going to be able to predict fully. So if they take 8 hours and they're suddenly having issues being on the vent, then you have to add a little bit of sedation back on board, then you escalate back up and then go back and do it again the next day. But yeah, and most of those patients, they'll just suction themselves out if they really need to.